Well, good morning, everyone. I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. As usual, we will go ahead and get started with some reminders, some logistics, and then introductions for today. Please be sure to join us next week as we will be hosting the annual Holtzgang Lectureship. Next week's talk is The Stuck Patient, Ethical and Legal Issues in Complex Discharge Cases, will be given by Dr. Kayhan Parsi. Grand Rounds is now a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are often available here live at Southern Auditorium at Providence St. Vincent on Tuesday mornings at 8 a.m. And sometimes our speakers are live at noon on Tuesday at Providence Portland. You can always watch the weekly invite to know whether we will be live in person. And it also has the link to join us on Teams Live. You can earn CME credit by being here in the room, by watching live virtual on Teams, or by watching a recording of the event. And again, that recording is also the same link as the Grand Rounds invite. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions that you may have for those of us joining online. And now to introduce today's speaker. Familiar to many of us, we are joined by Dr. Imran Mohammadi, who is a practicing infectious disease specialist. He went to medical school at Royal College of Surgeons in Ireland and then completed internal medicine residency here at our very own Providence St. Vincent, where he also went on to serve as chief resident. Dr. Mohammadi worked several years as a hospitalist and associate program director for our internal medicine residency before returning to complete infectious disease fellowship at OHSU. Now his professional interests include Staph aureus, cryptococcal meningitis, and non-tuberculous mycobacterial disease. And Dr. Mohammadi is known to enjoy woodworking, biking, and all things science fiction. Thanks so much for joining us to come teach today.
Thank you, everyone, for this opportunity. I have no relevant financial disclosures. I will be on occasion using some trade names discussing HIV medications, only because the generic names are quite long and cumbersome. And because the manufacturers of some of these drugs do a better job than I can, I did borrow their graphics to highlight some of the results from some of the studies. This topic is way too big to adequately cover in 50 minutes, so I'm focusing on some highlights of what has been going on with gonorrhea, chlamydia, and syphilis in the past decade, why screening is so important, and then some information on post-exposure prophylaxis and a brief update on HIV pre-exposure prophylaxis. If time allows, I'll add a spattering of a couple of other topics that I think are relevant for primary care. Trying to define the term sexually transmitted infection can be tricky, as there are over 20 sexually transmitted infections caused by various bacteria, viruses, fungi, and parasites. Not all of these are transmitted exclusively by sexual contact, but fit the definition regardless. Based on the CDC definition of STI, 1 in 5 people in the US have an STI, with an estimated incidence rate of 26 million new cases each year and an estimated $16 billion each year in direct medical costs. This is an estimate of the direct medical cost of STDs in the US based on 2018 data. Collectively, chlamydia, gonorrhea, and syphilis contributed $1.1 billion to this cost. The largest fraction is due to HIV at $13.7 billion. Note that the cost due to HPV dropped substantially since 2008 with introduction of the HPV vaccines. I would encourage discussion with all your eligible patients regarding the HPV vaccine. This includes young men regardless of sexual orientation, but in particular MSM patients and patients with HIV. The new age cutoff for the vaccine is 45 years old, but obviously the earlier the better. Currently, about 60% of adolescents 13 to 17 years old are fully vaccinated. So how is Oregon doing in terms of STIs compared to the rest of the country? This is data from 2023. It does not separate out Washington, D.C., which would be the region with the highest rates overall. The national average is 671.5 new cases per 100,000 population. Oregon ranked 40th in the state at about 540 new cases per 100,000. 7 out of the top 10 states with the highest STD rates are in the South. Vermont has the lowest STD infection rate. Mississippi ranked number 1 as the state with the highest rate of STDs at 1,300 new cases per 100,000 population, followed by Louisiana, South Carolina, Alaska, and North Carolina. New York ranks number 1 as the state with the highest rates of HIV cases. Southern states are more affected by chlamydia and gonorrhea. The green arrows are pointing to the 5 states with the lowest STD rates, and the red arrows are the 5 states with the highest STD rates. The overall STD rates tend to follow the overall access to healthcare, as outlined in this chart on state health system performances. But that doesn't explain the full picture, as racial and socioeconomic factors are likely also heavily influencing the STD rates. The green arrows also happen to point to the 5 states in the US with the highest percentage of white residents. Chlamydia is the most common notifiable STD in the US and in Oregon. Though rates reportedly dropped from 2018 to 2022, this was likely more a consequence of decreased testing during COVID. The highest risk demographic in Oregon are young women ages 20 to 29 and Black individuals. To be consistent with research protocols, when referring to men or males, please assume I mean people born male, and when referring to women or females, assume people born female. There are plenty of regional and smaller studies that do show that transgender women are the demographic at highest risk for gonorrhea, chlamydia, syphilis, and HIV, and that transgender women with HIV are at highest risk within that group for the other STDs. This chart is an age and sex-based distribution of case rates with chlamydia in the US. Highest at-risk groups are women aged 15 through 24 and men in the same age group. Women overall had higher rates. There are large variations in risk between races, with Black people at highest risk, followed by Native Americans and Native Alaskans. And geographic variation, as we discussed, for chlamydia, DC has the highest rates, followed by Mississippi. And for 2022, we ranked 39th for chlamydia. Gonorrhea is the second most common notifiable STD in the US and in Oregon. Case rates in Oregon had been on the rise until we saw a peak in 2020, and then a drop in 2021 and 2022, also potentially due to COVID. 1 in 10 men and 5 in 10 women will be asymptomatic with infection. The risk groups are similar to that of chlamydia. This is the case rates through the years in the US. We saw a steep rise in the 60s and 70s with a drop in the rates during the years of the AIDS crisis. Now in the last 10 years, we're seeing a rise again. The age and sex distribution shows, as mentioned, similar high-risk demographics to that of chlamydia, but with a more even male to female distribution and one that skews slightly more towards older age groups. Compared to chlamydia, there were overall higher rates for gonorrhea in men in total. This may be driven by the fact that men infected with gonorrhea tend to be more often symptomatic than women. We see a similar racial distribution to chlamydia and a similar geographic distribution in the US to chlamydia, with DC and Mississippi again having the highest rates for gonorrhea as well. Oregon ranked 40th in 2022 for gonorrhea. Overall, I think Oregon's doing a good job when it comes to gonorrhea and chlamydia. It is still worth having a low threshold for screening in appropriate populations. How do you identify an appropriate population? Well, you have to ask the sexual history questions and document them. Let your patients know that there's no judgment attached to the questions, but in order for you to take better care of them, you need to know what their risks are so that you can screen as needed and treat early when STDs are identified. There are plenty of guides for taking a sexual history, but I will just stress that it is important to get the details, get clarifications on things like open relationships, and familiarize yourselves with the current vernacular, especially when it comes to patients in the LGBT community. Most cases of chlamydia and gonorrhea are asymptomatic, so that is why routine screening is in higher risk individuals is critical. Guidelines recommend at least yearly screening in women under the age of 25 and in all MSM who have had more than one partner in the preceding year. This is supported by very strong evidence. There is lack of strong or even mediocre evidence to support the routine screening in other at-risk groups, but lots of expert opinion. In general, if there is concern for increased risk, one should be screened minimally at 1-year intervals, and in many situations more frequently than that. Individuals actively using methamphetamines or opiates, even without injection use and without any of the other risks, should have at least annual screening. In Oregon, I do think it is still reasonable to do annual screening in heterosexual men who in the preceding year were sexually active with more than one partner or a new partner. If they report 3 or more sexual partners within the last year or have had sex with an anonymous partner within the last year, they should get screened every 3 to 6 months. I typically recommend my non-monogamous MSM patients to get screened every 3 months for both gonorrhea and chlamydia with the urine test and a pharyngeal and rectal swab, depending on sexual practices. At minimum, they get screened every 6 months. With rare exceptions, sexually active people with HIV should be screened yearly. Anyone coming to you reporting concerns for an STD exposure should get screened despite when their last screening test was. This includes sexual assault victims as well. In men, sensitivity for urethral swab versus urine test was 97.8% versus 96.0% respectively. So urine testing is typically adequate for testing in symptomatic and asymptomatic men. Urethral infections in women always means cervical infections, but the reverse is not always true. Hence the difference in sensitivities between cervical swabs and urine sampling. As such, a fraction of cases will be missed if urine testing is done in women. These are some of the guidelines for when to and when not to use urine testing for women. If you are at the cervix anyway, do the swab. If the patient has signs or symptoms concerning for an STD or is at high risk, do the swab. Otherwise, a urine test is adequate even in women. There is some newer information about the sensitivity for a self-performed vaginal swab in women, and that actually surprisingly had pretty good sensitivity as well. Don't forget to ask about other sites requiring testing. If they engage in receptive anal sex, women should also get a rectal swab, and if they engage in receptive oral sex, they should get a posterior pharyngeal swab. It is important to know the classic illness script for urogenital infections with gonorrhea and chlamydia, as well as the presentations of the complications of urogenital infections. These infections can also present with non-urogenital symptoms that can be overlooked. In the interest of time, I'm not going to cover this, but I will at the end provide some excellent resources for review of these topics. I will just mention lymphogranuloma venereum, as there's been an increased risk of this in the US. LGV is a syndrome caused by a subset of chlamydia serovars. These isolates were much more prevalent in the tropics, but in Europe and North America, the rates are increasing, in particular amongst MSM. There is a higher overall risk amongst men living with HIV. Additional risk factors for LGV include having had another STD, international travel, and use of internet apps for sex. LGV has a classic presentation that includes a painless ulcer at the penis, vagina, or anal area, followed by development of typically unilateral painful lymphadenopathy. This can sometimes be accompanied by proctitis, especially in MSM. Though there are labs that can help diagnose LGV, these are not readily available and often take too long to result. When there is clinical and epidemiologic concerns for LGV and there's a positive chlamydia test, treat for LGV. In certain populations at highest risk, clinical concerns may be high enough to initiate treatment even before NAAT testing results are back for the chlamydia. There have been some changes in recommended treatments for gonorrhea and chlamydia as well. New guidelines all recommend, when possible, to use doxycycline for chlamydia treatment. Alternative regimens exist, but have concerns for higher failure rates. Patients need to be instructed on abstinence for at least 7 days after start of treatment, assuming symptoms have resolved by then. LGV treatment is the same as for a typical chlamydia, but for a 21-day duration instead of 7 days. Typically, if there is chlamydia proctitis, even without other evidence of LGV, treatment duration is recommended to be 21 days. For gonorrhea, since 2010, the CDC had recommended a single 250 milligram intramuscular ceftriaxone dose plus 1 gram of oral azithromycin as a strategy for preventing ceftriaxone resistance and treating possible co-infections with chlamydia. There are now updated guidelines since 2020. The change from the 2010 guidelines is based on the fact that there is increasing resistance to azithromycin and concerns that 250 milligrams of ceftriaxone was subtherapeutic at certain tissue sites, leading to increased ceftriaxone resistance. Overall, the likelihood of encountering an azithromycin-resistant strain is still low, as resistance is only about 6% or 1 in 17 cases. The new treatment guidelines recommend use of a single 500 milligram intramuscular injection of ceftriaxone or a single 1 gram dose for patients over 150 kilograms, which is about 330 freedom units. Though there are alternative regimens, this higher dose of ceftriaxone is the only reliable effective regimen for pharyngeal infections. If chlamydia co-infection has not been ruled out, the updated guidelines recommend adding oral doxycycline 100 milligrams twice daily for a 7-day course as well. Typically, no test of cure is needed for uncomplicated or asymptomatic infections, except for pharyngeal infections with gonorrhea. Regardless, repeat testing at 3 months is recommended given high rates of reinfection. If you suspect a resistance strain, try to obtain a culture in addition to the NAAT testing so that you can send it to the state for susceptibility testing. For confirmed cases of gonorrhea and chlamydia, providers should encourage the patient to inform the partner and request the partner get tested as well. When the partner might not be able to get screened and or treated, it is worth considering expedited partner therapy. This is where a prescription is provided to the patient to give to the partner. There are pros and cons to this that need to be considered. The big downsides are that often the partners won't get tested for other STDs. It's unclear if abstinence instructions are passed on. Potential allergy to the prescribed medication can exist. And in the case of oropharyngeal gonorrhea, the treatment may be inadequate. Here's some resources for EPT. This is a snippet of the provider fact sheet from the Oregon Health Authority, but I also like the Illinois Department of Public Health's patient handout to help patients explain EPT to their partner. For chlamydia, I typically do 2 separate prescriptions of doxycycline with instructions to the pharmacist on one of the prescriptions stating that it is for expedited partner therapy. For gonorrhea, the recommendation is still for intramuscular ceftriaxone injection for your patient, but a prescription for oral cefixime for their partner. During our, so turning to syphilis, again, I could easily spend 10 hours talking about syphilis. It's one of my favorite topics. There's a lot to talk about syphilis, but just to kind of keep it towards what's new and what's relevant, I'm going to just mention a few things. Rates are on the rise. High-risk groups, including MSM and sexually active heterosexual men and women between the ages of 25 and 35 are at highest risk. With syphilis, Indigenous people are at higher risk, followed by Black people. In Oregon, compared to 10 years ago, rates have increased 12-fold. As such, have very low threshold to check for syphilis in your at-risk populations and in patients presenting with unusual rashes or other unusual symptoms. I do think it's important. It's an important topic of its own, and I'd suggest these two podcasts that cover the topic very well as a refresher course. I'll just add a few words regarding testing, though. These are the commonly available tests for syphilis. We break them down into two categories: non-treponemal tests and treponemal tests. Historically, we've used non-treponemal tests first, followed by confirmation tests with a treponemal test. The non-treponemal tests have lower specificity and have a higher potential for false positive results, hence requiring that confirmation test. Historically, the confirmation tests have been harder to get and more costly, but with better specificity. These days, the treponemal tests are more accessible and costs have come down. In order to decrease false positive results and anxiety for your patient, the better approach is the reverse algorithm, with the treponemal test performed first that would then reflex to a quantitative RPR if positive. This is the preferred approach in patients who have had prior negative treponemal testing or have never had prior syphilis testing. If they have had a prior positive treponemal test, then they go straight to the RPR with reflex to quantitative titers. Prevention remains an important tool in addressing the public health aspects of STDs. Education remains the foundation of that approach, along with screening and early treatment to prevent spread. One new development is patient-initiated doxycycline post-exposure prophylaxis, or doxy-PEP. I'll mention this a little bit. This sub-study from France came out in 2018 as part of a larger study looking at pre-exposure prophylaxis for HIV. This was a randomized trial looking at the safety and efficacy of doxycycline as a strategy for STI prevention amongst MSM on PrEP. They found that doxy-PEP was associated with a 47% relative risk reduction. The risk reduction was primarily driven by reduced chlamydia infections, as the subgroup breakdowns showed no significant difference in gonorrhea infections and only a moderate but statistically significant reduction in syphilis. In April 2023, the doxy-PEP study from the New England Journal came out. This was an open-labeled, randomized 2-to-1 study on MSM and transgender women in the Seattle and San Francisco areas who were on pre-exposure prophylaxis for HIV or living with HIV. Additional inclusion criteria was that they had to have had at least one episode of syphilis, gonorrhea, or chlamydia within the preceding year at the time of enrollment. They were provided with doxycycline tablets to take 200 milligrams after, but within 72 hours of unprotected sex. They were monitored every 3 months for STDs. There was a significant difference in the study group compared to the control group in the combined incidence of gonorrhea, chlamydia, and syphilis. The number needed to treat to prevent a quarterly visit with an incident of an STI was 4.7 in the HIV PrEP group and 5.3 in the persons living with HIV. So on average, a number needed to treat of about 5. One downside is the concern for resistance that already exists for gonorrhea and worsening resistance to doxycycline in general with increased use of doxycycline for PEP. This graphic is from the research summary related to the same study. There was a slightly higher number of isolates of gonorrhea with tetracycline resistance identified in the doxy-PEP group. Skin and soft tissue infections with Staph aureus were fewer in the doxy-PEP group, but there was more isolates identified that were doxycycline resistant in the doxypep group. Though the IDSA guidelines have not caught up to the newest evidence, current CDC recommendations are to provide doxypep to men who have sex with men and transgender women who have had at least one STD within the preceding year, and encourage them to continue with every 3 to 6 month STD screening. The provider should provide instructions to take 200 milligrams of doxycycline, which is 2 of the 100 milligram tablets, ideally within 24 hours of unprotected sex, but no later than 72 hours of unprotected sex. They should also be reminded not to take more than 200 milligrams in 24 hours. Studies looking at this other populations have not had strong enough results to make the same recommendations, and likely the benefits in the US for heterosexual men and women are not outweighed by the increased risk, particularly the increased resistance risk for the various pathogens here. One study looking at high-risk women in Africa saw minimal to no benefits, but they also checked doxycycline levels in hair samples every 3 months and found very low levels, suggesting lack of doxycycline use in general. This is just a reminder to make sure I'm on time. My wife hates it when I show this picture because that was actually not a brand new plunger. I figured I'd take the picture first before I took it away. I just thought, anyway. So let's talk about HIV. Again, I could spend 10 grand rounds talking about HIV, but I want to kind of direct it to a few things that have developed in the last 10 years or so, but also just where do we stand with HIV recently. In 2014, the joint United Nations program on HIV and AIDS set the 90-90-90 targets, aiming to diagnose 90% of all HIV positive people, provide antiretrovirals to 90% of those diagnosed, and achieve viral suppression for 90% of those on treatment, with the hopes of reaching that goal by 2020. This would result in 81% of all HIV positive people on treatment and 73% of all HIV positive people achieving viral suppression. This is where things stood in 2016 in the US. 86% of those with HIV having been diagnosed, 37% on treatment, and 30% with viral suppression. Currently, we're doing better, but still falling way short of the goal. You can see here that in the US, we've achieved about 87% diagnosis rate, with 77% being on treatment, but 57 to 65% being virally suppressed. I'm not optimistic that we're going to have a vaccine for HIV in my lifetime. I'm not optimistic that we're going to have a cure for HIV even in my kid's lifetime. I think the focus needs to be on prevention of transmission using the tools we have now. Those tools include screening in high-risk groups with early initiation of treatment if HIV positive, and a push towards use of HIV pre-exposure prophylaxis in those who are eligible. It does require primary care doctors, urgent care doctors, and ER doctors to ask the questions about HIV risk, order screening tests for HIV when appropriate, and then either refer them for discussion for pre-exposure prophylaxis or have the discussion themselves. The CDC recommends that everyone between the ages of 13 and 64 get tested for HIV at least once as part of their regular health care. Some patients need more frequent screening. I think most providers know what constitutes higher risk for HIV. It's just a matter of asking the question to the patient to see if they are in that risk category. The National HIV and AIDS Strategy Group has identified additional high-risk populations that include minority groups within the MSM population, Black women, transgender women, young people in general, and people who inject drugs. Similar to gonorrhea, chlamydia, and syphilis, depending on an individual's risk, HIV screening should be done in higher risk populations at least yearly and ideally every 3 to 6 months. The recommended test for HIV screening in asymptomatic patients is the 4th-generation antigen antibody test with a reflex to confirmatory test. This test is not for acute infections or concerns for recent exposure to HIV, meaning exposures within 14 days. I think LabCorp has eliminated the preliminary reporting of results, so we see less issues with tests being reported as positive before the confirmatory tests have come back. But note there are 2 parts to the screening test. We do see several situations with discordant results, sometimes in the setting of early infection, and sometimes due to other non-HIV infections, including Epstein-Barr virus, Lyme disease, and syphilis. False positive antibody screens can also occur with lupus and rheumatoid arthritis, and even after certain vaccinations. In addition to the measures I mentioned for general STD prevention, we have options for prevention for HIV infection in higher risk groups using HIV pre-exposure prophylaxis. Most of you will be familiar with the oral agents Truvada and Descovy for HIV PrEP. If you've been on CNN late at night, you'll see ads for Descovy run every 15 minutes or so. Both have been around for several years and are very effective. Both have been shown on studies to suppress the risk for HIV substantially. Descovy is only approved for men as it may not achieve adequate concentrations in the vaginal wall, so we don't use Descovy for our female patients at high risk. These were the results for the Discover trial from 2020, showing quite good results for both drugs, but slightly better for Descovy. The benefit for Descovy was mainly in the better renal profiles and less bone demineralization due to its formulation using the TAF version of tenofovir. HIV PrEP was found to be less effective at preventing HIV acquired through injection drug use at around 75%. As of 2022, about 36% of those who could benefit from HIV PrEP were on PrEP. And of those, optimistically, 75% were using it consistently enough to get full benefit. So there's a lot of room for improvement in this regard. The big game changer in HIV PrEP has been injectable agents. Cabotegravir, which is the trade name for Apretude, is an injectable long-acting integrase inhibitor that received FDA approval in December of 2021 based on 2 quite robust studies. The first study, HPTN 083, looked at oral Truvada versus injectable cabotegravir in MSM and transgender women who had sex with men in a randomized, double-blind, double-dummy, non-inferiority trial enrolling over 4,500 participants in multiple centers across the world. This study showed superiority of injectable cabotegravir over oral Truvada in this population. Serious adverse events were similar in the 2 groups, and given it was a double dummy trial, both groups had injection site pain at similar rates. This was followed by HPTN 084 that looked at oral Truvada versus injectable cabotegravir in a randomized, double-blind, double-dummy superiority trial enrolling over 4,500 women in high-risk groups in sub-Saharan Africa. This trial showed significant superiority for injectable cabotegravir over oral Truvada in this group as well. Cabotegravir in this formulation is dosed typically at specialty pharmacies with dosing at day 0, 1 month, and then every 2 months. The most common side effect is still injection site pain. Its use is limited by insurance coverage, which is unfortunate. There are new formulations being studied that may be able to be dosed less frequently, which will make this option even more desirable. The big factor in getting people on it is that many people don't know about PrEP for HIV, and even fewer know about injectable options. This is where our primary care partners can help the most by identifying those eligible for HIV pre-exposure prophylaxis and then either referring them to the pharmacotherapy clinic directly or placing an ID referral. All right, one more time check. I think I'm doing okay. All right. I will mention very briefly that the numbers for MPOX are down, but not zero. In Oregon, so far, there have been 10 cases this year based on data through August. New cases were amongst unvaccinated or partially vaccinated individuals. Current CDC guidelines still recommend MPOX vaccine for certain high-risk groups. This includes sex workers and MSM and transgender women with more than one partner or who have had an STD in the preceding year, and MSM who have sex at commercial sex venues. The vaccines are still only available through the county health, though, so that's where they have to be referred. I think you can tell which drug website I lifted this from. Here's a list of several one-pill, once-daily regimens for HIV treatment. Having some familiarity with these, even though you're not the prescribing provider usually for them, is important. It's worth noting that when your patients are on an ART and you're adding any new medications, verify drug-drug interactions, especially if they're on a cobicistat or protease inhibitor containing regimen. Cobicistat is a booster, and like protease inhibitors, it has an effect on cytochrome P450, so making it a little bit less desirable as an option for ARTs for many of our patients. For those in primary care, if there's one ART that you need to be familiar with, it is Biktarvy, or Bictegravir, which is an integrase inhibitor plus emtricitabine and the TAF formulation of tenofovir. More than 90% of the time, this is the go-to ART for a newly diagnosed patient. Typically, for an effective ART regimen, we want a backbone of 2 nucleoside reverse transcriptase inhibitors plus one agent in another class, either an integrase inhibitor, protease inhibitor, or a non-nucleoside reverse transcriptase inhibitor. The preferred class for the other agent is the integrase inhibitors, though. They have very high resistance or high barrier to resistance, and they don't interact with other medications, which makes them very easy to start on a wide variety of patients. You don't have to worry about timing of dosing. You don't have to worry if they have to take it with food or no food. And it is the one that the guidelines all say, to go with as your first agent because of a lot of these aspects. It's also one of the most potent ones. We see viral loads come down very quickly on patients on integrase inhibitor-based regimens. There are a couple regimens that don't follow the classic component of 2 NRTIs plus one other agent. Dovato and Juluca are 2 such agents that do not follow this classic regimen structure. Though all of these are approved by the FDA as a first option for ART, Juluca and Dovato should be restricted to those in whom resistance mutations have already been confirmed and integrase inhibitor resistance has been ruled out. The other ones you can just start and wait for that result to come back. And then we modify them if need be, but they are safe to start and oftentimes effective, regardless of which of these you use. The newest kid on the block is Cabenuva, which is cabotegravir, the same long-acting integrase inhibitor that was in the pre-exposure dose Apretude. And to this, they added rilpivirine, which is an NNRTI. It's given as an injection, first 2 doses 1 month apart, and then every 2 months. Cabenuva requires viral suppression with a different regimen prior to start, so it's not a first-line HIV treatment. The big advantage of Cabenuva is compliance, and we find that our patients who have harder times taking their ART daily prefer this option. Cost remains a barrier for some patients, but there is financial assistance through the manufacturers, which opens this option up for more people. The general sense I get is that most primary care providers are more comfortable referring patients to us to start antiretroviral therapies. And I think that's fine. I do know that access to ID, especially in certain parts of the state, are limited. I think for providers in those areas who may be managing a patient newly diagnosed with HIV, having some comfort with initiation of ART is helpful, so as not to delay start of therapies. It is most helpful for those providers to also call and talk with the ID or HIV specialist that they're going to be referring the patient to, ultimately to get help with starting treatment, help order necessary blood tests and additional screening tests, and get some understanding if the follow-up is needed urgently or not. I try my best to keep PCPs in the loop on my HIV patients and make sure they're aware of any issues that may arise when I start or change an ART regimen on our mutual patients. I do ask them to keep me informed on which of the patient's routine healthcare maintenance aspects they're taking care of and which ones they want me to do. For the vast majority of people living with HIV, their HIV will not be what kills them. There are issues of increased risk associated with these three. We know that antiretroviral medications can have potential effects on bone demineralization. HIV, even well-controlled, has a negative impact on cardiovascular health, and HIV increases risk for HPV-related cancers. Since the 1990s, we've known about increased risk for anal cancer in people living with HIV despite their sexual orientation. Until recently, there's been debate mostly related to cost effectiveness of screening for anal cancer in this population. Very recently, the NIH released new guidelines on this and now are recommending men or transgender women who have sex with men and have HIV start screening with high-resolution anoscopy at age 35, and all other people with HIV start screening at age 45. We've been fortunate to have access to the anal dysplasia clinic at the France Cancer Institute at PPMC, but just as this new guideline came out, one of their providers left. So now we're going to be limited in our ability to refer HIV patients in a timely manner for that. We have known since the early part of this century that HIV, even if it is being treated, is associated with increased risk for cardiovascular disease. The ASCVD risk calculators are probably underestimating these risks, and as such, many of the patients who are in need of cardiovascular disease risk reduction strategies are not getting them. If the patient has any of these risk enhancing factors, I would recommend, if using the ASCVD risk calculator, to adjust up the 10-year risk percentage by a factor of about 1.5 to get a better sense of the actual risk, and then based on this new number, initiate risk reduction strategies. This may include smoking cessation, lifestyle modifications, including detailed instructions on aerobic exercise and diet, and starting a lipid-lowering agent. I highly recommend to anyone interested in more proficiency with STD to go through this online curriculum from the University of Washington. Provides a comprehensive review on the topic and get you some CME credit as well. They also have a very comprehensive module for HIV, but I think that's more geared towards ID fellows or people who want to do HIV as a large fraction of their primary care. In addition, there are several podcasts on the topic of the STDs, but the two Curbsiders episodes I mentioned earlier are great starting points. And with that, I'm happy to take some questions, and thank you for this opportunity.
Great. Thank you so much, Dr. Mohammadi, a whirlwind of information. I will start with just one comment online that notes that the Mpox vaccine is actually available at Credina at Providence, Portland.
Oh, nice. Okay.
Any questions here in the room?
Imran, I am just too old to get the syphilis testing cemented in my brain.
Yeah.
So ideally, you do a sensitive test first, followed by a specific test.
Okay, so you do an RPR first, followed by a treponemal test.
Right. So, and now you're saying to reverse that, which a screening test should be sensitive. So if the treponemal test is sensitive enough, why do we need to follow it with a confirmatory test?
Yeah, I'll stay here so that that's a great question. So the treponemal specific test, especially the antibody EIA tests now, are highly sensitive and specific, okay? So it is the preferred way to start. So why get the RPR then? Well, that has to do more with monitoring of treatment. So the RPR will give you a titer, and the goal here for treatment or decision on treatment is obviously a high titer that you treat and then follow, from my standpoint, at 3 months and 6 months, although minimum at 6 months, you want to see that RPR titer drop fourfold to know that you've adequately treated, okay? So that's part of the reason for getting the RPR still, is that you've made the diagnosis, now you got to monitor and see what your concerns are and whether you've treated adequately. It's not you're absolutely right. I think that's a misstatement on my part. It's more a monitoring test for, yeah. From the reverse algorithm, extremely rarely. From the original historic algorithm, way too often. It is one of the #1 reasons we get ask IDs or a consult is when a person is ordered the RPR, which is positive, and then they tell the patient they have syphilis, and then we order the treponemal test, and then it's negative. And the groups that are at most risk for this discordant is your rheumatologic, diagnosed patients. Lupus, RA will have an effect on the RPR as will other rheumatological conditions.
Great, thank you. We'll go ahead and field a couple questions from online. Can you remind us, is there data on injectable PrEP for patients who use IV drugs?
There, unfortunately, no studies have been done in that population, but I would anticipate that we'd probably see similar results to what we know about Truvada and Descovy in terms of efficacy for injection drug users in terms of acquiring HIV. So again, the guesswork would be 75% effective, which is better than 0. Again, I think it's still worth it if they're willing, but with the understanding that it may not be as effective.
Great, thanks. And we have an online question here from one of our own other infectious disease specialists. Any updates on drug-resistant gonorrhea that is circulating?
Yeah, so definitely that is the big worry amongst the ID community as well as primary care. Rates are on the rise for resistant gonorrhea, which is why I think it is important that if you do a second, not a test of cure, but a second screening test, and in the same site you find the gonorrhea still there, those patients you should try to get a culture sample. It's easier in men, especially if they have discharge, to get that sample. It's a lot harder in asymptomatic patients. The pharyngeal swab is okay. Again, the NAATs are easy to get, but the cultures are trickier to get enough of a sample to adequately grow the gonorrhea, which is very hard to grow to start off with. The tests are only performed at the state. we're fortunate, at least in Oregon, that our rates are not crazy high. The East Coast is seeing much higher rates of drug-resistant gonorrhea, and internationally, they're seeing much higher rates of drug-resistant gonorrhea. And so, yeah, that's kind of the update on that. I don't have much more information on that.
You've done your nap.
You can finish that.
So do you bring them back in then for the culture before treating them? Because, you know, presumably we do our NAT, we get the result, we wouldn't make them come back in, we would just call them and put them on treatment.
Right. So so the short answer is yes. So this is for the people who you test the second time in the same site, and you're going to start with a NAT test regardless. And if that's positive, yes. Before you initiate treatment, you have them come back, try to get the swab. The outcomes here have been kind of mixed bag because it's been very difficult to get an appropriate sample to send.
Many thanks for this great talk. On the topic of swabs, in the clinic, are you allowing patients to self-collect? There's been a movement towards self-collecting even pap smears in primary care.
Absolutely. So like I mentioned, for female patients, the newer data says that a self-collected vaginal swab is probably just as adequate as a cervical swab done by the provider. So that population, yes, you have good evidence. We actually have these little like laminated sheets to show them how to do the various swabs. I don't let them self-swab pharyngeal. It's just A, it's mean, and B, it's usually not adequate. They usually don't get a good sample. So even if I'm not doing it, our MAs are trained to do a pharyngeal swab. And then for rectal swabs, yes, for the most part, unless they have some reason why they don't want to do it or can't do it, then we let them do their own rectal swab with the instructions that it has to be inserted 1.5 inches into the rectum, give it a few spins, and then put it into the container. I usually show them how to do it with the pharyngeal, and then that way they know how to insert it into the tube, break it off, and leave it for the MAs. So yes, and most of my HIV patients that we're doing this for prefer that.
Thank you. Another question here, going back to screening for HPV-related cancers and some challenges with access to the dysplasia clinic, for example. So if anoscopy is not available, what about anal PAPs?
Yes, so that is the next best option for patients for screening for HPV-related cancers. I know Kaiser has their own available to them. Like I said, the Franz Institute is where we were sending people. I'm hopeful that there will be more options opening up, but at the same time, OHSU has its own, Kaiser has its own. I don't know if Legacy has its own. I would imagine that they do, and ours is going to be limited probably until they get another provider, which I'm hopeful will happen in the next few months.
I'll pause online questions to take one here in the room.
Thank you for that great talk. I have a question about PrEP and wanted to know your practice. Do you tend to now go for Descovy or Truvada and leave Truvada only for women?
Yeah, a lot of it comes down to insurance and what they're willing to pay. Descovy is still slightly more expensive for a lot of our patients, but if the option is available, I will definitely choose Descovy. There's enough evidence to suggest that TAF regimens are better for your patients in terms of bone demineralization and renal risk. So it's unfortunate that Truvada, which has a higher bone demineralization risk, is the one that's only allowed for women because they're the ones that are going to be at highest risk ultimately. The thought, though, is that the time frame that you're using PrEP is probably fairly limited. It's not a lifelong thing for most patients. There's an age for some that it makes most sense for, although that age is broadening somewhat, given you've seen where gonorrhea and chlamydia have gone. I don't know that I can necessarily make that argument for much longer, but at least the risk overall is probably not as bad as, say, if a person was on a TDF regimen for HIV for their whole life. Okay, so my go-to is still Descovy. And if their insurance allows it and they're willing, and you'd be surprised how many people are willing, I counsel them on Apretude, on the new injectable, and say, hey, you don't have to think about it. You just show up once every 2 months, and like I said, maybe every 4 months or potentially even every 6 months to get an injection that's going to give you substantial protection from HIV. And I think we should be encouraging that, because then you know they're on it. Like with the pills, it's always hit and miss. And like I said, optimistically, 75% of my patients who are on Truvada or Descovy are taking it at a consistent level to provide adequate protection.
Hi, Imran. I don't have a specific question, but wondering if you could comment on on-demand PrEP and if you have any specific guidance on that or how you approach that with patients.
Yeah. So I haven't had to deal with it very much. There were a couple of situations in terms of travelers. One was a traveler who knew he was going to have, probably anonymous sex when he went to a certain country. And the other situation was a female traveler who was afraid that she was going to get raped and therefore wanted PrEP beforehand. The thing about that is you have to have started it at least a month before for it to be fully effective for the orals and for the injectable. So it's kind of harder to recommend the on-demand aspects. There is some emerging data that suggests that maybe if you start at 72 hours before planned, unprotected sex, that there may be some benefit, but I don't think there's been large enough studies to really make that claim strongly enough.
Great, thank you. We are going to come back full circle. We can't get enough of syphilis testing. One more question. So for a screening test in an asymptomatic patient with no specific risk factors, if the treponemal test is equivocal and the RPR is negative, any reason to repeat further steps? What test?
I think you would probably start with a repeat of a treponemal test, maybe using a different treponemal test, but at the same time, that's the algorithm I would still use. And I think, yes, they should probably retested in no sooner than 2 weeks, but retest no later than a month to verify that status.
Thank you, Dr. Mohammadi. You have an answer for everything.
I make up some as I go too. So.
I think this was touched on briefly in your talk. Can you give any comments on recommendations regarding safe sexual practices when it comes to prevention of sexually transmitted infection?
Absolutely. Again, abstinence is the best, but obviously that hasn't worked for the last 50 years or so. Condom use is good. Condom use for HIV prevention, for prevention of gonorrhea and chlamydia is quite effective. For syphilis, somewhat less so, but at the same time, I still think it's worth recommending condom use for anybody who's engaging in sex with another person who may be at risk or who we don't know what their risks are. Outside of that, depending on the type of sex or the sexual practices, there's a lot of things that are higher risk and there are a lot of things that are lower risk. There is a study that looked at men who have sex with men and transgender women who have sex with men, where they looked at transmission rates of gonorrhea, either from rectum to the penis, from penis to vagina, from the penis to the oropharynx, from the oropharynx to the oropharynx, which there is a risk of transmission with what they refer to as deep kissing, of gonorrhea transmission, even with deep kissing. So gonorrhea is very, very contagious. And just making sure your patients know that they may be more prone to using condoms in those situations. There is also some evidence to suggest that Listerine or an oral wash before you deep kiss or have oral receptive sex can be effective at decreasing transmission risk as well. I think condom use is where I usually start with most of my patients and just say, hey, there is no better thing outside of abstinence than to use a condom at this stage. And if you're worried, let's get you on doxypep and let's get you on HIV pre-exposure prophylaxis so that your anxiety about these issues can go down substantially. And a lot of them are very accepting of that when you approach it that way.
We have made it to 9 o'clock. Thank you so much, Dr. Mohammadi.
Thank you.